Hello, how is everybody?
Hi, how's it going?
I'm very good, thank you.
I'm also doing good.
Hey, Ebenezer,
No,
I can't see your face properly.
my room is the
Nice of you to come. Anna,
Hi, how are you?
I'm good. Who else is here? Wow. Okay. How do we do it? Okay, let's keep it for a couple of minutes, a couple more minutes to come. And once we are in, I think this is an opportunity to quickly introduce ourselves. Basically, tell us your name, what you are doing, and perhaps why you decided to join today. So when I mention your name, then you go. I'm just going to read the names from what I can see on my screen right now. So we'll start with Anna.
Hi, everyone. My name is Anna. I'm located in Canada, and I'm currently a PhD student at a Canadian university. It's the University of Ottawa. I'm studying chemistry, and I was invited by Kimeli. This is my first global cafe, so yeah, it's going to be interesting to hear what the speakers have to say.
Thank you. Then we go to the next person is Mary, but we'll talk about Mary. We go to Ebenezer.
Yeah, hello.
Hi.
Can you hear me?
Yes.
Okay, my name is Ebenezer from Ghana. I'm a nurse by profession. This is my first time joining Global Lab, and I got a link through WhatsApp and through our Global Lab page.
Okay, then we go to Kwesi Ochri. Yeah, I knew it.
It's me, Fred. I am a PhD student in Lancaster, UK. Don't worry, my name keeps changing each time I join all of these meetings. I have no control over what name shows up. So,
It's all right. Well, yeah, I just maybe one day you become Gabalian. I'll be like, what's happening? Yeah, okay. Yeah, I'll just keep that at the back of my mind.
So it's Fred.
Oh, I think we are done, right? Because the other people is two princesses. Are we recording already?
Yes.
Okay, great. Okay, so since those of us who are here have already introduced ourselves, I'll just go ahead and we start. So basically, I just wanted to share a little bit about Global Lab and why we are doing this program today, and then we take it up from there. We had about more than 50 people register to participate, so I'm hoping we'll have a few more people join later. All right. So let's see. Can I see my screen? Hello?
Yes.
Can you see my screen?
Yes, we can.
Okay, great. Okay, so as you've already seen from the advertisement, the Science Cafe for today is focused on coronavirus. It's something that I've been discussing with various people to organize since the start of the pandemic, but due to the fact that we had to keep social distancing and the complexities that the pandemic has imposed on our day-to-day lives, we were not able to do it until now, but which is great because this has allowed this has given us the opportunity to reflect and also like come up with various projects and initiatives that we are all undertaking. And interestingly, we have perspectives from 3 wonderful speakers who have done some work directly relating to the pandemic. So we would have some really nice and brilliant ideas to think about. So basically, why should something like this be important? Like we are all into the sciences. We all see science as something which is very valuable for society. But then again, every now and then, we realize that there's this huge gulf between science and society. Ghana invests very little, less than 1% of our GDP in the sciences, for example, and this is a problem that exists in many African countries and indeed countries around the world. But the long and short of it is that oftentimes we realize that scientific insights do not inform policy or how we do things as it should be, and therefore, we don't develop or we don't move as fast as we should. So, if you take the case in point with the COVID crisis, for example, there is always this back and forth between what is supposed to be the right thing that should be done in order to protect the public, and this is a worldwide problem. So, I mean, many people see public engagement with scientists and the lay public engaging constantly to be one way to help to address this challenge. And science communication has evolved as a field, and all kinds of practices have been introduced in order to do this. So in Global Lab, we see this as also interesting because if we convene sessions where we exchange, what happens is that, for example, somebody who may be a technologist who may not be all that versed in the health field gets to understand certain basic health concepts, or somebody who is a doctor who needs technology to power their work gets to network with someone who knows the tech, right? So we begin to exchange and we begin to network in a way that would enable us to be able to respond to challenges that we have in our communities. So basically, Global Lab started, like some of you know, once upon a time in Keta Secondary School, basically as a Facebook group, just to kind of like have this platform for students to ask questions or connect them to scientists or experts in an informal and not like the proper classroom environment, right? But over the years, it's evolved to be a platform that is looking at how do we leverage our passions, our knowledge, and our expertise to solve community problems using science and technology as a tool. So that's what Global Lab is about. And so I came up with this reflective model, kind of showing that, first of all, you have to come together and then begin to engage and then take action and then share best practices. So in the spirit of engagement, Science Cafe has been one of the tools that we use. And basically, Science Cafes have been going on all over the world for a while now. And basically, we are like, why not organize Science Cafes in Ghana? And why not organize it in different settings? So the first picture you see, top left, was the very first Science Cafe. Was led by Darlington, who is into artificial intelligence, sharing more about the prospects of artificial intelligence for Africa. The next one, that's the top right, that was in African Science Academy, where we talked about broadly about science and society and why young scientists coming up should concern themselves with this topic. We organized a special session during Africa Science Week in Accra, again talking about 3 core areas that we thought were of importance for national development. And in the bottom left, you can see Dr. Angela Tebri sharing about mathematics and how mathematics can help in terms of development and its connection to various topics. So this is Science Cafe. at a glance. And then the picture at the bottom right is from the last in-person science cafe that we had in January. Some people from Global Lab and our speaker who is at the University of Kassel in Germany. So what is the business of the day or the science of the day, as I choose to put it? We are here to talk about COVID and its implications for public health and well-being. And luckily, we have three people who have done brilliant work in different areas of this topic. Our first speaker is Princess. She'll be presenting on the epidemiological trajectory of COVID-19 in African countries. So it's a data science-based work, just trying to show us how the pandemic has been spreading in different African countries. The speaker after her is Dr. Mary Eyram Ashinyo, who is with the Ghana Health Service. She's a physician with expertise in many public health policy analyst. She's a lot. I mean, we met a couple of years ago. We've always been talking about doing a science cafe together. So when COVID came and I realized that she was part of the national team, I was like, finally. And she'll be talking more from the community participation, but also offering some more perspectives in terms of policy. And then we have Joseph Sam, my own TGSS brother, who also came up with an innovative approach to allowing the borders to be opened, because that's one of the questions: when will the borders be opened? And Joseph has some ideas as to how that can be done safely in different countries. So without much ado, I would invite Princess to start. I have the profile, so maybe I'll be reading them later. But Princess's profile is very short, so I can read it from my mind. She's a senior at Center College in the US, studying mathematics and data science with a minor in education. And so we are very happy to have you, and thanks for joining today's session. And carry on.
Thank you, Gameli. So I'm just
I think I have to.
Mhm.
Yeah, okay. Yeah, please go ahead.
I'll have to set up my presentation, but I think you are still presenting, so I can't.
Yeah, I'm trying to click different things.
Okay, let me see if I can.
What is happening?
So present the Chrome tab. Okay. I think I can override yours.
Okay, yeah, it's kind of frozen. I don't know why.
Yeah, I just did. Okay. Okay. Awesome. So, okay. Okay. Hello, everyone. My name is Princess Allotey. As Gameli said, I am a senior at Center College in Kentucky, USA, and I am majoring in math and data science, and I am minoring in education. So this idea for this project actually started from a class I took in the spring semester. That was last semester, where we were told to choose a data science project of our choice and to kind of explore it. So that was a time when COVID was like really big in the US, and most of us were told to either go home or stay on campus if you can't go home. And I was like, well, there's data out there on COVID, so why don't I explore it with what I have learned in class like during that semester? So my presentation is on the epidemiological trajectory of COVID-19 with a focus on African countries. So just some background information. COVID is an infectious disease and was discovered in Wuhan, China in December 2019. And as at 30th January, it had been declared a pandemic by the World Health Organization. And by June this year, it had spread to more than 200 countries worldwide. And I think that's one interesting thing about studying COVID, finding out or exploring how a disease started in a particular location, in a particular country, and within a period of about 6 months, it was able to spread to more than 200 countries worldwide. So just my big idea questions. My project was kind of got a focus from these big idea questions. So my first big idea question was, what is the trend in COVID cases over the days under study? So here, looking at time series data, how many cases are we having as the days go by, in terms of continents, in terms of countries, in terms of regions? My second question was, what are the patterns in how the indicators in the data set relate over time? So here, when I say indicators, I mean certain factors that might have affected the virus or the spread of the virus. So for example, what kind of testing policies do these countries have? Do these particular COVID patients have access to good healthcare? What is the population density of this particular area where there's COVID? So these kinds of indicators. My third question was, can we predict the likelihood of occurrence and the rate of occurrence of COVID in the near future? So can we use current data to predict how the COVID infection curve will be like in November this year? So that was one question too I had. My last question was, can we also predict the likelihood of occurrence of COVID? But here, considering information on existing patients. So if we have information on existing patients, can we use that data to predict the outcome of future patients? So these are my four main questions that kind of gave me the direction of my study. So just my data sources, I got data from four main sources. My first source was Our World in Data. Our World in Data is an online publication platform, which is led by a research team at the University of Oxford. My second source was from the World Health Organization. I also got data from Johns Hopkins School of Engineering. I also got data from GitHub. So for GitHub, there were different sources. One of the sources I got data from was from the Oxford COVID-19 government tracker response. So for example, what they did was that they were tracking information on different policies, so testing policies, closures, and containment policies. So they were kind of tracking it and finding out what different countries were doing at different periods of time. So for the indicators that I talked about in my previous slide, so these are just examples. I'm just going to go through just a few of them. So for example, location. How does your location affect the chance of you getting the virus? So if you're in Wuhan, China, is there a high probability that you're going to get the virus right now? If you are in Ghana, what is the probability that you're going to get the virus? So confirmed cases, death, tests. So tests was one really important thing, because for most data I got, there was data on the number of infected people was dependent on the tests that happened. So if there was always an undiagnosed population which has not been tested, which have the virus, but we might not know until you get tested. So that was another indicator. Stringency index. Stringency index is more of how strict countries were on like testing policies or containment closures and things of that sort. Population density, age. Which age groups are more susceptible to the virus? GDP per capita, extreme poverty. These two might kind of relate to how much a country or a location might have access to good healthcare. Death rate, diabetes prevalence, smokers. So these kind of relate to specific patients and their susceptibility to the virus. Hand washing facilities, travel history location, which is really important. Market exposure, additional information, which I'll talk of very soon, and then chronic diseases. So looking at whether existing patients or future patients might have had chronic diseases, and that might have affected their chance of getting the virus. Location, travel history binary, the outcome. So whether they eventually died from the virus or they live, whether they were discharged early and things of that sort. Access to an intensive care unit, access to a ventilator, testing policies, what kinds of testing policies were introduced in particular countries or particular regions, life expectancy, containment and closure policies, and hospital beds per thousand. So these are examples of indicators or things that can be explored to be able to learn more about the virus and its mode of spread, or factors that could affect the infection rate of the virus. So for my methods, I had four main methods. I used four main methods. My first method was the logistic model, and it's an S-shaped curve. So it assumes that the infection goes in an S-shaped curve. I'll talk about it very soon. My second method was the neural network. So with neural network, the main thing I used it for was on time series data. So on data on the number of infections every day or the number of deaths every day, example. And I use it to predict future COVID cases. My third model was the SIRD model, which I'll talk more of later. So with the SIRD model, it's actually the susceptible, infected, recovered, dead model. So at a point in time, everyone in a particular location is either susceptible, infected, recovered, or dead. So that was a model I also used. And the last model I used was a natural language processing. So that kind of looked at text data on different existing patients and was able to train on it and learn and give information on the outcome of future patients or the outcome of current patients. So for the logistic model, so there's one main assumption for the logistic model. It assumes that the COVID curve is a logistic curve. And for the logistic model, I used data on COVID from as early as December 31st to as late as 7th June. And the parameters I used was looking at infection speed. How fast does the infection go? The day when maximum infection occurred, the total number of recorded infected people at the infection's end. And in the next slide, in the next couple of slides, I'm going to show some graphs, and the x-axis is going to be the number of days since the first confirmed case, and the y-axis will be the total number of infected people. So first, I looked at Africa as a whole. So I got data from 52 African countries, so that was very helpful. And the first case was on December 31st, 2019. Sorry, that was a mistake. December 31st, 2019. And my logistic model predicted that COVID will end collectively in Africa on 29 January 2021. So the red circles are the real data and the blue is the logistic model. So you realize that it's the real data actually does follow the curve of a logistic model, and that was kind of interesting seeing. I also looked at Nigeria. So for Nigeria, the first case was on February 28, 2020, and my model predicted that COVID will end in Nigeria or would flatten. The curve will flatten in Nigeria on November 14, 2020. I also looked at Central African Republic, and you also realize that the real data closely follows the logistic model. And the first case was on 16th March, and it's predicted that it will end around November 23rd. The next one was Mauritius. So for Mauritius, it does not closely follow the logistic model, but then it's also predicted that by July 15th, COVID would have tapered off or would have flattened. And that was kind of interesting because we've already passed July 15th. So I went online to check on the curve of Mauritius and to find out if they still have their cases climbing. And it was kind of interesting finding out that around mid-July, the curve was flattening. So I thought that was interesting. So the next curve is for Ghana. So for the case of Ghana, you realize there's something really odd going on. So the real data a little bit follows a logistic model, but then you realize that around where we have more than 8,000 cases, it's going exponentially up and it's not really following the model. But I added this just to show the limitations of a logistic model. There could be some limitations to it. So for Ghana, our first case was around March 13th, and it's predicting that the COVID will end in Ghana on October 31st. So for the recurrent neural network, which I call the neural network, there are different, let's say, kinds of recurrent neural network, and the one I used was a long short-term memory, that is the LSTM. So the assumption for this model is that the current number of COVID cases depends on the previous number of COVID cases. So it's saying that if I got data on the number of COVID cases for yesterday and 2 days ago, I can predict how many COVID cases we'll get today. So the approach it used was that I got a lot of rows of data, and then it trained on a particular percentage of the data, validated on a particular percentage, and then it's predicted for the rest. So if I have 100 rows of data, for example, it trained on the first 70, validated on the next 20, and then tested on the last 10. So what happened was that it first set a baseline prediction, which I'll show in the next slide. So for the picture on the left, we have the baseline prediction. So what I mean is that it's first of all giving a rough estimate of its prediction. So the green dots, for example, is the model prediction, and the true future is the X. So you realize that the prediction is not very close to what we wanted it to be. But then when it sets this baseline, it now works to beat that baseline. So that's what the recurrent neural network is doing. And you realize in the second picture that it beats it much better. And I want to say that for this particular model, it's a work in process, and there's not really, I'm not really talking a lot about the applicability, but it kind of gives a sense on how you can use previous data to determine future cases of COVID. The next model, which is my third model, was the SIRD model. So with the SIRD model, there are 4 assumptions I used. So my first assumption is that at any time, a person is either susceptible, infected, recovered, or dead. And when you become susceptible, everyone who has not yet gotten the virus is susceptible. So when you are susceptible, you can either get infected. When you get infected, you can either recover or you die. And when you recover, my assumption was that you can't get infected again. And when you die, you can't join the susceptible again. So it's more like it's a feed-forward network. So you're always going forward, you don't go backwards. So that's where I said that's where my fourth assumption comes in, that the model is not cyclic, it goes forward. And going back to my third assumption, I'm assuming that an infected person eventually recovers or dies about 3 weeks after they get infected. And that was a really crude assumption, but it kind of helped with the model and can be made better. So I did an SIRD model for Ghana in particular. The picture on the left represents the infected population, a time series representation of the infected, a time series representation of the recovered, and also the dead. But then the graph on the right shows a time series representation for susceptible. The reason why I did not combine these 2 graphs was that the susceptible population is so high that if I combined them, it was going to scale infected, recovered, and dead to be just a line. That's why I separated them. So looking at susceptible, that's the picture on the right, you realize that the number of susceptible people is going down as time goes on, which makes sense because they are moving, some of them are moving to infected. So looking at the graph on the left, you realize that for the infected population, it went quite high as time went on and then reached about a peak around late June, and then it went down and came up again. But you realize that it's rising again. And I think it will be interesting to explore why it rose again. Is it because people were not allowed to come out? Is it because the lockdown was now a partial lockdown or things of that sort? And also for the recovered population, we realize that it's going up as time goes on. And the dead population is not really changing as much compared to the infected and the recovered, which I guess is good news. So my last model was the natural language processing, and there are different tools you can use for natural language processing. I use NLTK, which is a natural language toolkit. So the goal for NLTK, which is the one I'm very much interested in, so what the NLTK does is that it's trying to predict whether a COVID patient will eventually die or survive the pandemic. That's the main thing. So it's looking at a binary situation, die or survive, 1 or 0. So for the data set, I got a really huge data set, which had about more than 1 million rows of data on COVID patients. So every single row is data on a COVID patient, and it had numerous columns. It had columns on the age of the patient, the outcome of the patient, additional information. The additional information column actually had information on whether they've traveled before, which countries they've traveled to, what diseases, whether they have a chronic disease, whether they've had a chronic disease on. So it's kind of like an unstructured column, but with a lot of text data. So the approach for the NLTK was that there was a function. So it took in all the text data, created a bag of words with it. So for example, if you say maybe sick, ailing, sickness, so all those words kind of relate to the same thing. So it's kind of grouped all those kinds of words together as common words. So that's why it was creating a bag of words. And if you have maybe a word like do, doing, done, did, they are all kind of relating to the same thing, but just that they are in different tenses. So it's kind of, the function also works with those kinds of words and joins them together as common words. Then it trained on an odd number of models. So for this data it trained on this data, but it trained on secondary models. So it's used an odd number of models because of the last approach, the fourth approach, which is voting on the outcome. So for example, if you have model A, model B, model C, model D, and model E. So each model is going to train on the data and give a result for an outcome for each patient. So let's say if model A says this patient will die eventually, if model B says this patient will die eventually, if model C, D, and E say no, this patient will live eventually, with a voting mechanism, since live had 3 votes and dead had 2 votes, the NLTK will spit out that the actual outcome of the patient is that they are going to live because they had 3 votes for live and 2 votes for dead. That's why we use an odd number of models for this case. But then it has its limitations, I might say. So I use NLTK for the whole world, so world data on all the patients who are from any country in the world, so wherever. And so this is a confusion matrix. So basically what it's showing is that it's showing us the predicted and the actual. So if you look at the diagonal, so we have 4,298 and we have 85. So the 4,298 represents the fact that the model predicted that 4,298 of those patients were going to die, and actually they eventually died. The 85 in that diagonal also means that the model predicted that 85 of the patients were going to live, and actually they lived. And then if you look at 6, so 6 is saying that the number 6 there represents the fact that the model predicted that 6 of the people were going to live, and actually they died. So that's where the limitation of NLTK, the limitation of using models comes in. And the 234 represents the fact that the model predicted that 234 patients were going to die, and then actually they lived. And the accuracy was 94.81%, which someone might say is quite good, but it has its issues because if, for example, I share this data with the Ghana Health Service and they used this kind of model to predict which COVID patients should have the priority to be given ventilators, if there's a limited supply of ventilators, or should be sent to the intensive care unit, or should be given like more access to healthcare because there's a high probability that they are going to live from the virus. And I send this model to them. It has a 94.81% accuracy, so that's quite good. But what about the about 5% error? Because if my model predicted that a patient was going to die, and they were not given the priority to be given a ventilator, for example, and they actually were going to live, that is a really expensive cost. So it's important to consider these kinds of issues. I also looked at specifically African countries, and the diagonal is kind of the correct accuracy, the correct it spits out like the correct values. So here it's predicted it predicted quite well. So it's predicted that 48 of those patients were going to die, and they actually died. And it also predicted that 5 of those patients were going to live, and they actually lived. It also predicted that 4 of those patients were going to die, and they actually lived. And you also realize that the accuracy here is quite lower than that for the world. So this was 92.98%, which is quite good. But as I said in my previous slide, it has its costs of like using a model like this if it's not a really, really, really high accuracy. So for conclusion and future work, I did this research because 1, there's a growing need to learn more about the virus, its mode of spread, and different indicators of interest. And I focus mainly on African countries for a part of my study because I wanted to contribute to current research on the continent. And the models I used was the logistic model, the recurrence neural network, the SIRD model, and natural language processing. And for future work, I plan to get more up-to-date data sets. So as time goes on, there's always up-to-date data on COVID. So right now, if I went to the World Health Organization website, or I went to any of my data sources, I'll get so much aggregated data on COVID. So I'll have to update it and develop more rigorous models. So for example, the recurrence neural network, I would have to make it more rigorous such that it gives a much better model prediction. And also, I plan to expand this project into the fall semester as my data science capstone project. So that's something I'm really considering. And I think this research or this study actually might relate to medical informatics. So it'd be kind of interesting to also explore that particular field in terms of what data I have and how it relates to data science. So these are my references. Thank you.
Yes. Yeah, Princess, thank you very much for the presentation. I should have mentioned when we were doing the introductions or at the beginning stage that yeah, so the idea behind this is that now that you've made your presentation, we have two other speakers who are also coming to share their perspectives with us. So I would like to give either Mary or Joseph the opportunity. If you have any like question or any thoughts, yeah, you can just bring it out, or you can ask Princess a question. Because also I'm interested in the connections between what each of you are doing. You know. Okay, well, I have a question, and my question is that now that you've done findings, if you want to relate it to Ghana, what would be like the top two things that you recommend to be done in Ghana?
The top two things I recommend. I think one thing is the testing policy. I don't know exactly how it's done in Ghana now. But I think if testing is something that is made very accessible to a large part of the population, it's helpful because we'll be able to diagnose the undiagnosed population. Because as I said, most of the data out there gives information on the confirmed cases, which are usually from the diagnosed population. But there's always an undiagnosed population, which might be infected, but we don't know as at now because they've not maybe had access to testing, or they've not gone for testing if they can. So I think that's one thing that will be really good to introduce. And I think it's also good. I think that's something Ghana is already doing, but I think it's also be good for Ghana to also try to continue learning from other countries, maybe countries that had worst case scenarios, let's say Italy, for example, or the US, or countries that were really able to contain the virus. So it'd be good to learn from those countries and learn what they did that did not work, or what they did that really worked, because those would be really good case scenarios to look at. However, it's important to say that the Ghana ecosystem might be different, and there might be different factors that could affect the rate of spread of the virus that might not really be existent in Italy or in the US. So it's important for me to add that too.
Oh, okay. All right. Thank you very much.
You're welcome.
Yeah. Does any of our speakers have any further question or comment?
Can I ask a question if that's okay?
Okay, yeah.
So Princess, good job, good presentation. So for your different logistic models, I just wanted to know, does it take into account certain changes? So like, for example, right now the borders are closed, and right now people are, or I guess countries are transitioning out of lockdown. So is that taken into consideration? And even if like there was a vaccine that was introduced, is that also taken into account in your different models?
So the logistic model does not take that into account. It only takes into account the time series data. So that's why the assumption for that model is that the disease follows a logistic curve. And I think for the logistic model, it makes that assumption because it usually looks at like really big, a lot of data. And usually those kind of indicators, I mean, they affect the spread of the virus, but collectively, during a long period of time, it kind of smoothens to be a logistic curve. So for the logistic model, it does not really consider that. For the SIRD model, it just works on time series data, so it does not really consider that information. For the neural network tool, it does not, but for the natural language processing, I could say it does in some extent because it does not only consider time series data, it considers additional information. And in those additional information, it's unstructured data. So there could be information on whether a lockdown was introduced during this period, where the person could not travel, or things of that sort. So I would say the natural language processing would consider those kinds of indicators. But for the first three models, they mainly consider time series data.
Okay, great. Thank you.
You're welcome.
Hi, Princess. This is Joseph. Great job. I'm very excited to see the results of these models. They paint a very interesting picture. I'm going to talk about the logistics model, and I'm curious to know, you specified the date that the first case was recorded, right?
Mm-hmm.
Now, what we've realized is that these are like the official cases or the first when it was first detected, but anecdotal evidence suggests that some of these cases may have been around, even before when the cases were officially being tracked and recorded. So it will be interesting to see how you can compare what you have now versus, let's say, the date of the first case. For instance, using Ghana as an example, the first case is March 13, 2020. It will be interesting to see that what if we change that date to, let's say, a week or 2 weeks before? How would that look like? So that we're actually getting closer to the true start date versus official start date. I'll be interested to see how that curve will be like, whether it will still follow the logistical model and taper as it should. And then secondly, I'll also be curious to know, to see a comparison in terms of countries and the way they track the COVID-19. I'm looking at I'm moving to the NLP, where you're looking at dead and alive. The reason is that we've made to understand that different countries have different criteria for declaring that this person died of COVID-19. So there are countries where someone, if you're in Ghana, you will say you died of COVID-19. If you're in another country, they will say something else. They will say probably pneumonia or something else, right? So different countries have different criteria for determining who is dead, who died out of COVID-19. It will be interesting to see how, if you take one country versus another country, what the NLP and the confusion matrix would say, whether there will be a vast disparity, and then we'll know for sure whether people are really properly classifying the deaths as they should, or for other expediency and other, image reasons and other things they choose to, not label them properly so that the numbers don't appear to be rising. That would be a very interesting thing to see.
Yeah, I also think that would be really interesting to look actually for the second thing you talked about. Because with the data I have, one thing I realized was that it was kind of improportional in terms of which countries there was data from. So for example, for the Johns Hopkins website, for example, they mostly give information on data from the US. So it was more aggregated for different states. But for most African countries, it took time for me to actually get a lot of data for them. So I think it would also be interesting to look at that in intersections like what you said on who declares who was dead and how different countries go about that.
Awesome. Thanks.
You're welcome.
Okay, thank you, Princess, very much. So we'll move on to the second presenter. This is Dr. Mary Ashinyo. Hello, Mary, are you there?
Yes, hello.
Okay, so I'm going to help you. I'm going to display your presentation and run it for you. Is that okay?
Yes, that's perfect. Thanks.
Okay. Yeah, I'm just going to read quickly in case you didn't see the bio when we just put it out yesterday. So Mary is a physician specialist, that's physician specialist public health and a health policy analysis fellow. She currently works for Ghana Health Service at the national level as a deputy director of institutional care division responsible for quality and safety. Previously, Dr. Ashinyo worked as a medical superintendent in the Ghana Health Service and has received several awards in recognition of her grassroots work, including the Mandela Washington Fellowship from the U.S. Department of State in 2015, the Young Physician Leaders Award from the Inter-Academy Partnership and the World Academy of Sciences in 2016, and the World Leaders in Global Health Award from the Stanford University Center for Global Health in 2017. Dr. Ashinyo is a member of the Ghana College of Physicians and Surgeons, holds a master's degree in public health from the School of Public Health, University of Ghana, a diploma of advanced studies in health care and management from the Swiss Tropical Institute of Public Health, Switzerland, a certificate in public management and leadership from Howard University in Washington, D.C., USA, and other certificates of management and leadership from the European School of Management and Technology, Berlin, Germany, and GIMPA, Ghana Institute of Management and Public Administration, Accra, Ghana. She loves reading, shopping with the girls, and watching cartoons with her family as hobbies. So she's gonna present to us on like the public health dimension of COVID, and looking specifically at the topic of community participation. So Mary, thank you very much for giving us the opportunity to hear your insights on this topic.
Okay, so thank you very much, Global Lab, for the opportunity as well. Good evening, ladies and gentlemen. Thanks for coming. And we've been talking about the coronavirus crisis and what it means for public health and well-being. This will continue as a 2-year series. So I decided to just focus on the community participation in health because I think that is something that runs through all the major functions of public health. Thank you. So the WHO states that health is a state of complete physical, mental, and social well-being, and not just the absence of disease. Looking at this definition, it means that most of us are likely not to be called healthy because although we do not have any identified disease, like we don't have malaria or even COVID-19, we may not be mentally healthy or socially healthy. So that is to say that health should be a very holistic definition that looks at all aspects, including physical, mental, and social well-being. And it is also good for us to look at what public health is because that is the bigger basket in which we are situating our discussion. Public health is a science, so it's a science just like any other science, but it is not complete without the arts bit of it. So it's both a science and an art. It's a practice. So it's the science and art of preventing disease, prolonging lives, and promoting health through organized effort and informed choices of society. So that is why I feel community participation is extremely important because right from the definition of public health itself, you see individuals, communities, at the center of the definition, which means that public health is not public health without the participation of communities. So it is very important for us to understand what makes communities participate in health for well-being. So this has been known since the practice of public health, but the coronavirus crisis itself has emphasized the role of public health functions in ensuring the well-being of human and non-human populations. As you are aware, we have moved a step from global health, which has been mainly focused on human health, to planetary health, which tries to link human health to non-human populations. So what we already know previously has been emphasized by the coronavirus crisis. Next slide, please. So public health seeks to achieve health for all, which has been our mantra, and not leaving anybody behind. The main purpose of public health practice has been to prevent epidemics or pandemics and the spread of disease. And that is why the COVID-19 crisis become very important because the WHO has declared it as a pandemic and currently in all countries. Public health also seeks to protect human health against environmental hazards. So there's been all the discussion about climate change and how they impact health of humans and non-human populations. Also seeks to prevent injuries in all forms, whether thermal injury, physical injuries, etc. It promotes and encourages healthy behaviors. So there's a lot about health promotion in public health because a lot of health outcomes depends on human behaviors. It also responds to disasters and assists communities in recovery. So in Ghana, for instance, when there's a disaster, we have NADMO that goes around to provide various forms of assistance to communities to recover. Those are all public health practices. It assures quality and accessibility of services, and that is where my department sits as quality assurance for the Ghana Health Service. So it's a public health function to assure services and to make sure that access to quality care is given to everyone, irrespective of geographic location or social status. So the entire core functions of public health is grouped into three. There's a bit of assessment. So assessment means that we have to regularly determine the level of health of a population, and then also determine the gaps and where we want to get to. And out of that, we develop policies and we implement those policies and we assure services. Next slide, please. The public health community also has 10 recognized essential services. So, for instance, the first one is to monitor health status and to identify and solve community problems. And this is done by using various indicators to measure the quality of life or the reverse. So, for instance, we can look at simple indicators like maternal mortality, child health mortality, and so on and so forth. These are indicators that help us to monitor the health status of any group of people. Another function of public health is also to diagnose and investigate health problems and health hazards in the communities. And this diagnosis is not just laboratory diagnosis. Even investigating, for instance, maternal deaths is a form of a diagnosis of a problem. And this is very important for COVID-19 because the previous speaker talked about testing capacity and testing reforms. Public health relies a lot on laboratory testing of health problems in the community because that informs decision and policy. The third one is to inform, educate, and empower people about health issues. This is because public health people recognize that people are very central to health outcomes. And for people to take the right health decisions, they must be educated, they must be informed, they must be empowered to be able to participate in that partnership between communities and policymakers or health systems actors. Public health practitioners also develop policies and plans that support individual and community health efforts. They enforce laws and regulations that protect the health and ensure safety. And these laws can start from local laws to international laws like the International Health Regulations, Public Health Act, etc. And even within the context of COVID-19, we saw some executive instruments that went out to make sure that people were wearing masks. All these are public health functions. Public health testings also link people to the needed care that they want to receive. And so we talk about referral systems. They assure a competent public and personal health care workforce and human resource capacity building. They evaluate effectiveness, accessibility, quality of personal and population-based health services. And the last, obviously not the least, is research. One of the criticisms that Ghana's response has come under is the fact that we haven't seen a lot of investment into research. When we have seen other countries do some research, we haven't seen a lot from the Ghana side. So these are the essential public health services. And it is important to know that for each of these services, there are implications when we look at COVID-19. And so I have brought these essential services for us to just see how wide the scope of public health could be. And the discussion must extend around all these essential services of public health if we want to talk about COVID-19 and the lessons that it brings to bear. However, what ranks through all the essential public health services and all the core functions of public health is the community participation bit, and that is what I decided to share with you today. So this means that implications for public health can be very diverse across all the 10 essential public health services, across all the core functions of public health, across the purpose of public health as mentioned previously, but also importantly across the relationship that public health as a discipline has with other disciplines of sciences. So how public health relates to cardiology, internal medicine, pediatrics, soil sciences, environmental science, all other sciences. There are implications of COVID-19 and the discussion could be very broad. But again, community participation is at the center of all this discussion. Next slide, please. So the first lesson that has come to bear is the fact that we need to begin to recognize the complex relationships when we talk about health. And I believe we have already realized how complex health has been because people talk about complex adaptive systems and how health extends beyond health itself. We have seen governments and countries take decisions on COVID-19, even based on economic concerns rather than core health concerns, based on social and political concerns rather than core health concerns. And so this is just to say that the world has become a much smaller global village than we knew it because of COVID-19. We have seen that health it's a very complex relationship from funding to how information is shared on social media to how communities connect to how health systems are available to air travel to internet connectivity to transport systems to energy systems. Health really goes beyond the core health system and can be very diverse. And so what improves health services and well-being can be then summarized into three. The first component are the public health programs, then the clinical services, which if we look critically, is actually a public health function. But in our context, it stands on its own. And the third one then comes as community participation. So in summary, what improves health is a combination of health systems planning and management and community action. Not forgetting that health financing is very, very key across all these. And we are hoping that various countries across the world who are at various percentages of funding as total of their GDP would gradually get to 15%, especially in Africa, where most African countries are hovering around 5 to 7% of GDP. We also need to begin to look at the social, political, and economic determinants of health, because these have become even more emphasized in the context of COVID-19, and how all these other factors impact health is extremely important. Whilst we also plan to improve health and well-being, we must not lose sight of the six building blocks of the health system, which include health governance and leadership, which also talks about policies that give direction to improving health and well-being, logistics supply. We have seen challenges with vaccines, medications, personal protective equipment, etc., in the COVID response across the world. Health financing cannot be emphasized. Human resources, their capacity, their morale, how much resources they have, how much equipped they are to be able to provide services for well-being. Health information, data is extremely important, and we saw in the last presentation how data has been used to model to predict the trajectory of diseases. Then, of course, service delivery, because when community action fails and populations contract diseases, ultimately they need to have services that will ensure that they survive. Next slide. So community participation is the active involvement of people from communities preparing for or reacting to disasters. So if we want to talk about what community participation is, it means that we have to involve people in the entire agenda setting, policy implementation, policy formulation, its implementation, and even the evaluation of it, the entire cycle of it. That is what we will call community participation. So that means that in decision making and planning and in program implementation, all these stages need us to involve communities and make them feel that they are part of the process. And we have seen this in Ghana's health systems, particularly at the community level of the system, which we call CHIPS, where we've seen our community health officers partner with community health management committees to plan health services and bring health very close to the doors of people in communities. And this has been seen in many, many countries. What is important for us to recognize is that community participation is very voluntary. We do not force people to participate in the process of health planning and delivery. And so there must be something that connects policymakers or people who drive health programs or public health programs to the community members that makes community members feel that they have that responsibility to behave in a certain way that improves the general health of the. Next slide. So community participation really goes many ways, many years back. When we look at the 1948 Constitution of WHO, it states that informed opinion and active cooperation on the part of the public are of utmost importance in improving health. And we have seen this in the COVID response. Primarily, we first try to prevent the spread of the disease. And when we need that, it means that all the interventions that we put out, for instance, social distancing, wearing masks, washing of hands, all these require community effort. It is not now the policymakers who try to do social physical distancing in the community. It is community members who decide to take those actions. And so WHO has recognized this way back in 1948. But it was not until the 1960s and 70s that practical benefits of community participation and ownership of it, health projects began to attract increasing attention. So this had been on the table for many years, but it took a while for people to give that recognition that look, communities must be at the center of decision making in public health. And even that, there's still a really long way to go. In 1978, the full participation of the community in multi-dimensional work of health improvement became one of the pillars of the Health for All movement. And the Health for All movement is still the one that we talk about currently in public health, and community participation is key. And in 1986, the Ottawa chapter signed at the first International Conference on Health Promotion identified strengthening community action as one of the key priorities for improving health. Of course, communities' participation to improve health can just not be overemphasized. And since then, we've seen both positive and negative setbacks. We've seen communities mobilize resources to improve health in their own communities, but we've also seen communities mobilize themselves against key public health interventions such as vaccine trials, for instance. It is worth noting that the actual capacity of community to participate in defining and implementing health agendas has been a very important discussion and has been limited by resource constraints. People need information to be informed, to make the right decisions, to feel more confident that they can actually partner health systems in improving health. And that requires resources. And so resource constraints have been one of the challenges among others. In some jurisdictions, gender, race, and class discrimination play a very key role. We've seen that in the United States, for instance, where initially, although we thought that the Black race offered some protection against COVID-19, we realized that most of the people who were dying in the US at the point were actually Black people, because US didn't have universal health coverage until Obama introduced Obamacare and Obamacare. And luckily, on the day that Obamacare was signed, I happened to be in the Capitol on one of my fellowship programs. And so I was privileged to witness that historic celebration. And so gender, race, class discrimination play a very critical role. People do not have the voice and the power to be able to participate in decision making. Nevertheless, communities have taken part in many other useful public health projects. In Ghana, the CHIPS is an example where it's a vehicle for virtually everything about primary health care, including sanitation, nutrition, vaccination, disease control programs. And recent reviews have shown that community action indeed is increasingly resulting in significant improvement of health of populations. Next slide. Now, I want to come back home to Ghana and look at what we did as a country during the COVID response. And these 5-pronged objective has repeatedly been mentioned in almost all the briefings of the Ministry of Information. At the beginning, we wanted to limit and stop the importation of the virus. So there was this compulsory quarantine of persons traveling into the country. 30 points of entry were locked. And then we had 2 cases on the 12th of March. And the next thing was then to contain the spread of the virus, because the virus had already entered Ghana. And certainly people were getting sick. So we needed to put in appropriate systems to care for the sick. Then we realized that health was beyond just the health sector. And so we needed to limit social and economic impact of the virus on people's lives. And people are already complaining. COVID-19 has made foodstuffs more expensive. Businesses such as saloons don't get customers anymore because people are not going to weddings, etc. I can go on and on and on. But we also try to expand domestic capacity for self-reliance. So we had local companies that were producing PPEs and other logistics to be able to sustain the response. So next slide. So this framework that Ghana used, I must say, was quite comprehensive and should have really helped us to contain the virus, perhaps more than we did. We are doing now. Although we are doing okay from a public health perspective, the figures look okay. It has helped us to attain a case fatality rate of 0.5% as of June, when I wrote this paper for the BMJ. Implementation of these strategies has seen challenges just like any other African countries have seen. And these have been both systems factors but also community factors. I'm very much interested in the community part because the community action was really important for us to be able to break the transmission of the virus. And one key phenomenon that I picked up was the fact that people were not wearing the mask. People were not keeping social distancing. When you drive outside Accra or Kumasi, nobody wears masks. You ask yourself, is this still Ghana, or maybe we have just left Ghana? It was so different, especially outside Accra and Ashanti. So I tried to find out why, and I realized that there had been some weaknesses in our communication strategy. Next slide, which has resulted in the fact that we were not able to really mobilize the community on our side. So a study done by Chris et al., they found that just about 44% of people were wearing masks on the streets of Accra, and that is quite disturbing. People still gathered at funeral, street parties, etc. For hand hygiene, perhaps we do it better because it's been speculated that our eating culture, we always wash our hands before eating fufu and banku. And so hand washing was not really a problem for Ghanaians. They could easily do so. Many factors that would contribute to a picture such as this one, where people do not comply to protocols. We first of all have to ask ourselves, are the masks really affordable? Would the picture have been different if government distributed free masks? So that is a question we have to answer. But did people really even believe that they had to wear the mask? Assuming that they had them, did they believe that masks were supposed to be worn? And then were the protocols being enforced? These are all questions that one could ask. Next slide. But one of the key things that I picked up why people were not wearing masks is the fact that people did not believe that there were coronavirus cases in Ghana. And that is just because we as policymakers did not create that trust through information sharing. And so people didn't even think the virus was in Ghana. First of all, they said that the figures on the website were not consistent. And I remember it was a whole discussion on joy. Number of people tested, samples tested, and it was a whole argument. So the figures were not consistent. From the system's perspective, they were just hiccups. But again, communication with communities is one thing that could build a lot of trust or otherwise. So once they are not on the system side and they cannot perceive that these were systems hiccups, it is interpreted as policymakers trying to manipulate data. Secondly, we didn't really show Ghanaians where the COVID-19 patients were. In other countries, there were videos that went through hospitals showing people who were sick. Prime ministers who had the disease were on TV. We saw them. But in our situation, even the prominent people who had the COVID-19, we could not leverage on them as COVID champions. Some even denied that they didn't have the virus. And so if these people could not make us believe that there were COVID-19 patients in Ghana, then why should my grandmother in the village, for instance, believe that there were COVID-19 in Ghana? So subsequently, this kind of relationship with policymakers and communities did not build enough trust to be able to make the communities participate in complying with preventive protocols. And so this is a phenomenon that I picked up, social capital, which I have come to realize, or COVID has taught us, that social capital is extremely important in engaging communities. In layman language, you can look at it as trust. It is embedded in our social relationships, how we communicate between policymakers and communities. And this has been noted in the literature to drive communities to modify their behavior for mutual respect, but for mutual benefit. But if communities do not feel that, or they do not trust what we tell them, then it becomes very difficult for them to modify their behavior. Because we already stated that it is voluntary, community participation is voluntary. And so major elements like social networks, civic engagement, norms of reciprocity, and generalized has become very, very important when we want to engage communities. Next slide. So if we are able to engage communities through appropriate communication, be it on social media or on very formal networks, then we will begin to see communities as resources for health and not just end users. Then we will move beyond community awareness about health to their participation, because first of all, are they aware that there's coronavirus? Yes. But secondly, do they believe us enough to be able to participate in the process? And we must not forget that wherever we find ourselves, the focus should not just be on the content, but also the context that we are in and the various actors that are in the game. Next slide. So in conclusion, effective public health campaigns require active support from the population, and this means that policymakers must identify appropriate tools for engaging community to be able to make them participate in the process. Thank you very much, Global Lab, for the opportunity.
Okay, thank you. Yes, thank you very much, Mary, for your insights. It's been powerful. I'd like to give the opportunity for anybody who might like have a question to do so. I also want to mention quickly the opportunity for asking the questions through the chat. I see Ebenezer has already started something like that. So if you have a question whilst somebody is speaking, you can feel free to put it in the chat so that I'll check it and then maybe call on you to ask it. Are there any questions for Mary?
Hi, this is Joseph.
Or comments?
Okay, sorry, quickly a question. Mary, thank you. Wonderful submission, very enlightening. I would like to know, would you say it's too late now to regain that trust, that social trust, or to rebuild that social capital? And if not, what exactly is being done to do that?
Thank you, Joseph. That's a very important question. I think that at any point of the policy cycle, we could win the community to our side. In a situation such as an outbreak of an infectious disease, where most of the preventive protocols depends on the population, I think the most critical stage to gain that trust is the beginning of the process, where we are in the preparedness stage. Because the other aspect is human psychology and behavior. It gets to a point like currently where people are at the stage of learned helplessness. It's as if they are tired and people are really not even listening to any health promotional messages. So it should be possible to gain that trust at all the stages of the process. But the best time is the preparedness stage, where there's a lot of anxiety and there's hunger for information, and people really want to prepare themselves to remain safe. Thank you.
Okay.
Yeah. Can I make a comment and then a question?
Yes.
Okay. Thank you for your presentation. And as part of your presentation, you did mention the issue of trust and the issues of how the initial communication led to an erosion of trust. And I think in part that's because to some extent it became a political issue. It moved from a health issue to kind of scoring political points in some sense. What lessons do you think we can learn from that so that in future health issues we try to not score those sort of political points on both sides? Because once we get into the political point scoring, then people would fake news and so on is thrown into the system, and then it confuses everybody, and the trust is lost.
Thank you very much, Kwesi. Those are very important reflections. And I think health itself, public health itself, is politics. There's a scientist who said health is nothing but politics on a larger scale. So it is really difficult to separate health and politics. So I also mentioned political, social determinants of health. It's a very tricky situation and not entirely possible to separate both, because when you also look at the response, you see that there are areas, the pillars that extend beyond Ministry of Health and then goes into other ministries, which overall oversight lies with political leaders. So that becomes a little difficult, especially when politicians, as we know them, will definitely have some rent-seeking behavior. They are taking the opportunity to also campaign. So they say, oh, we are distributing food to the homeless, but actually there's an element of campaign in there. It's just how society is organized. And I think that is one of the reasons why, if communities are really empowered, they can take appropriate decisions for themselves and would be in a very good shape. Thank you for that. Very useful.
Yeah, thank you very much, Joseph and Fred, for your questions, and Mary for answering. I mean, when I was listening to your presentation, it just took me back a little bit to like school. I mean, talking about public health and the social determinants, and why it's very important to move away from a very